Hello, student doctors. It's nice to see you again. Welcome to second year Skin, Blood, Lymph. My name is Jeff. This lecture is called Introduction to Antibiotics. Let's get started. Here is an outline of the lecture. First, let's go over learning objectives. There are 5 learning objectives in this lecture, starting with, in order to treat patients with bacterial infection, you should be able to recognize specific antibiotic drug classes as belonging to one general antibiotic mechanistic group. You should be able to relate the mechanism of action of an antibiotic drug class with mechanisms of antibiotic resistance. Learning objective 3, you should be able to predict how different antibiotic drug classes will interact if given in combination. Learning objective 4, you should be able to choose efficacious antibiotic drug classes for specific bacterial pathogens based off of distinguishing bacterial characteristics. And finally, learning objective 5, you should be able to understand and recognize the common side effects or adverse effects of a given antibiotic class or individual agent. The following 4 slides are brief introductory material. Bacteria come in different shapes, to include spherical, rod-shaped, and spiral-shaped and other shapes. Spherical include Streptococcus, Micrococcus, and Staphylococcus. Rod-shaped include Bacillus anthracea, Salmonella, and Clostridium. Spiral-shaped include cholera, Helicobacter, and Treponema pallidum. Importantly, Treponema causes syphilis. Some key terms and concepts include the definition of antibiotics: substances or compounds that kill or inhibit the growth of bacteria. Endogenous antibiotics occur in our nasal mucosa and tears. There are natural products, the molds such as Penicillium and Cephalosporium, that produce antibiotics, the primary example being Alexander Fleming's discovery of penicillin, with Staphylococcus aureus being killed by invading Penicillium mold colony. You can see the zone of clearance. Other key terms include bacteriostatic versus bactericidal agents. In the absence of antibiotics, bacteria can multiply. Bacteriostatic antibiotics prevent bacteria multiplying, and bactericidal antibiotics kill the bacteria. There's differences in their spectrum. Some antibiotics are broad spectrum, while others are narrow. Now let's talk about bacterial machinery. There are various aspects of bacterial machinery that are targeted by antibiotics, to include cell wall synthesis, membrane integrity, protein synthesis, folate synthesis, DNA and RNA synthesis. Towards the left are those types of drugs that target gram-positive bacteria. Towards the right are those types of antibiotics that target gram-negative bacteria. Here's a list with a lot more details regarding the specific bacterial machinery targeted by antibiotics. Here is a list of key antibiotics classified by their mechanism of action, to include cell wall synthesis, integrity, DNA synthesis, other aspects of DNA, RNA polymerase, phospholipid membranes, protein synthesis, specifically 30S inhibitors or 50S inhibitors. This slide further depicts the different mechanisms of actions of key antibiotics, an additional broad overview for your perusal. Moving on, let's get into the specifics of the antibiotics. Digging deeper, there are different classes of antibiotics. This slide is providing you a broad overview of 12 classes of antibiotics. The key provided denotes such as chloramphenicol and oxazolidinediones. They commonly act as bacteriostatic agents restricting growth and reproduction, whereas those in more of a blue-green color commonly act as bactericidal agents causing bacterial cell death. There is also an interesting timeline of the discovery of antibiotics, showing you just how recently in our human history these drugs have been in use. Discovered in the 1930s, beta-lactam antibiotics are the most widely used antibiotic in the northern hemisphere. Examples include penicillins, cephalosporins, and their common mechanism of action is the inhibition of bacterial cell wall synthesis. Up to 5 to 10% of patients allergic-like side effects. Most of these reactions are minor to include mild rash, itching, or skin flushing. Only a very small fraction of these patients will have a serious reaction when challenged with another beta-lactam antibiotic in the future. With respect to anaphylactic reactions, these drugs rarely do produce this life-threatening type of reaction. It's less than 0.04% of drug administrations, and it's not the most commonly observed side effect. Benzathine penicillin has a specific structure shown here. When used to treat syphilis, a reaction known as Jarisch-Herxmeyer may occur. Its use during pregnancy is generally safe. It's given by injection, active against gram-positive bacteria, as well as gram-negative bacteria, specifically in the treatment of syphilis, which is caused by Treponema pallidum. Now, I'd like to talk about one of the penicillins, specifically piperacillin. In order to understand piperacillin, you're going to have to understand beta-lactamase enzymes. So some bacteria produce these enzymes to endow them with resistance to certain antibiotics. You can see here bacteria streaked on a dish are treated with discs. Each disc is impregnated with a different antibiotic. The clear rings on the left show that bacteria have not grown, indicating that these bacteria are not resistant to the antibiotic, whereas the bacteria on the right plate show that some resistance to all but 2 of the 7 antibiotics tested. It's important to note that penicillinase is a subtype of the beta-lactamase enzyme. It's expressed by bacteria that remain sensitive to oxacillin, which is resistant to degradation by this family of beta-lactamase enzymes. There are also bacteria that produce so-called extended spectrum beta-lactamases, or ESBLs for short. These are multi-drug resistant strains of bacteria. There's a class of drugs called beta-lactamase inhibitors. They're used in combination therapy together with a beta-lactam antibiotic. One example might be tazobactam. When combined with piperacillin, they coordinately function together to bind the beta-lactamase enzyme more efficiently when compared with the beta-lactam antibiotic alone. The combination of these two drugs, piperacillin and tazobactam, also known as tazocin or zocin, is an important combination medication for Pseudomonas infections. There are serious adverse effects associated with these two drugs, including the rise of C. diff infection, allergic reactions to include anaphylaxis. Those who are allergic to other beta-lactams are more likely to be allergic to piperacillin-tazobactam combination. Let's talk about ceftriaxone. Ceftriaxone is a third-generation cephalosporin beta-lactam antibiotic. It's used to treat E. coli, pneumonia, meningitis. It's also used in a common bacterial infection found in young women. It's called acute pyelonephritis. Let's talk about a second-generation cephalosporin called cefaclor. Cefaclor is a bacterial cell wall synthesis inhibitor. It has a 6-membered ring, and that's compared to other penicillins that have a 5-membered ring attached to the beta-lactam core. Cephalosporins are structurally different enough than penicillins to only have 1 to 2% cross-reactivity because of this difference. So risk of cross-reactivity is acceptable when patient has a history of minor allergic-like reactions. The risk is not considered acceptable if the patient has had a history of anaphylactic reactions to other beta-lactam antibiotics. I want to talk now about 2 very important beta-lactam antibiotics: methicillin and oxacillin. Methicillin susceptible Staph aureus MSSA versus methicillin or oxacillin resistant Staph aureus, also known as MRSA and ORSA. MSSA and MRSA are 2 types of Staph aureus. People carry it on their skin and in their noses, but it does not make them sick. People generally don't even know that they have it until an event gives it entrance into the body. IV needles, surgery, a wound, skin condition, all can cause life-threatening sepsis. The defining difference between MSSA, MRSA, OSA, and ORSA lies in how they respond to methicillin and or oxacillin respectively, 2 antibiotics that were introduced in the 60s to treat staph infections. MRSA and ORSA produce penicillinase. It's a subtype of beta-lactamase, but can be treated with vancomycin or other new antibiotics. The second most prescribed antibiotics in the northern hemisphere were discovered in the 1950s, and those are macrolides. The prototypical example is erythromycin. Other examples include clarithromycin and azithromycin. Macrolides inhibit protein synthesis in bacteria, leading to cell death. An important adverse effect associated with macrolide antibiotics is inhibition of cytochrome P450 drug metabolizing enzymes. Inhibition of P450s can produce cardiac effects to include QT prolongation and torsade de poids, so-called twisting of the points. This is a life-threatening drug-drug interaction driven by erythromycin-mediated inhibition of drug metabolism in patients on combination therapy. Aminoglycosides is a large family of over 20 antibiotics. Its mode of action is to inhibit synthesis of proteins by bacteria, leading to cell death. Prototypical example is streptomycin, but additional examples include neomycin, kanamycin, and paromomycin. All contain sugar substructures. The most frequent clinical use of these drugs include sepsis, complicated intra-abdominal infections, complicated urinary tract infections, nosocomial respiratory tract infections. Once cultured, the causal organisms are grown and their susceptibilities tested. Aminoglycosides are discontinued in favor of less toxic antibiotics. Chloramphenicol is a distinct individual compound. Its mode of action is to inhibit protein synthesis by bacteria. It's no longer a first-line drug in developed nations due to the increased resistance and safety concerns. It's used by mouth or by injection into a vein. It treats meningitis, plague, cholera, and typhoid fever. There are common side effects, especially in children. There's a syndrome known as gray baby syndrome, and it results in a swollen stomach and low blood pressure. Glycopeptides, including vancomycin, are common drugs of last resort. For many years, vancomycin has been relied upon as a go-to drug for treating multi-drug resistant MRSA and ORSA. As a result of its increased use, bacteria have developed resistance to vancomycin, and that is now a growing concern. Its mode of action is to inhibit bacterial cell wall biosynthesis. With respect to quinolone antibiotics, such as ciprofloxacin, bacterial resistance evolves rapidly to these drugs. Other examples include levofloxacin, trovafloxacin, and they all interfere with bacterial DNA replication and bacterial transcription. For patients with sickle cell disease, quinolone antibiotics are quite useful. They're the drugs of choice due to their ability to enter bone tissue without chelating it, as tetracyclines are known to do. So clinically, quinolone antibiotics are used for genitourinary infections, hospital-acquired infections associated with urinary catheters, and community-acquired infections. Cipro is recommended only when risk factors for multi-drug resistance are present or after other antibiotic regimens have failed. Serious acute cases of pyelonephritis, bacterial prostatitis, and hospital-acquired pneumonia. Discovered in the mid-1990s, oxazolidinones are used as drugs of last resort. They inhibit synthesis of proteins by bacteria. Clinically, linezolid attacks gram-positive bacteria that are resistant to other antibiotics. Vancomycin resistant enterococci and methicillin resistant Staph aureus or MRSA. Main uses are infections in the skin and pneumonia, as well as use in drug-resistant tuberculosis. Oxazolidinones can be taken either by injection into a vein or by mouth. Sulfonamide drugs were amongst the first commercially available antibiotics. Sulfanilamide is a prototypical example. Other examples include Prontosil, for which its discovery and commercialization was awarded the Nobel Prize. Sulfadiazine, sulfasoxazole. This was used by the Allies in World War II. Sulfonamides don't kill bacteria. In other words, they're bacteriostatic, and they definitely can cause allergic reactions. Currently, they're primarily used for treatment of vaginal yeast infections. In 1937, an elixir of sulfanilamide was synthesized using diethylene glycol as a solvent. At that time, it poisoned and killed more than 100 people as a result of acute kidney failure, prompting new U.S. regulations for drug testing. In 1938, as a result, the Food and Drug Cosmetic Act was passed, and that gave birth to the current FDA, which regulates drug formulations in this country. It was only the solvent and not the drug that was a problem, as it was being used safely in both tablet and powder form at the time of this event. Discovered in the 1940s, tetracyclines inhibit synthesis of proteins by bacteria as they are bacteriostatic. The prototypical example is tetracycline. Additional examples include doxycycline, limicycline, and oxytetracycline. They're active against gram-positive and gram-negative bacteria, chlamydia, mycoplasmas, rickettsia, and protozoan parasites. They're only effective against multiplying organisms. They're to be avoided during pregnancy because they've been associated with transient suppression of bone growth and staining of developmental teeth. Tetracyclines are the treatment of choice for infections caused by chlamydia, rickettsia, brucellosis, and spirochete infections. Antimycins, including geldanomycin. Other examples include rifamycin, naptomycin. These drugs demonstrate antiviral activity against bacteriophages and poxviruses. These drugs inhibit the synthesis of RNA in bacteria, leading to cell death. They're used against many gram-positive and some gram-negative bacteria. For example, the treatment of tuberculosis, leprosy, and AIDS-related mycobacterial infections. There's a class of antibiotics called Streptogramins. These are two groups of antibiotics that act synergistically. They provide greater activity than the combined activity of the separate components. Originally manufactured as feed additives, in current times there's increased interest to combat vancomycin resistant bacteria. Clinically, vancomycin resistant Staph aureus, vancomycin resistant Enterococcus represent two of the most rapidly growing multi-drug resistant strains of bacteria. So these drugs are of interest in that regard. Lipopeptides are drugs that disrupt the cell membrane function, leading to cell death. One example is daptomycin, the structure of which is shown here. Other examples include bacillomycin, echinocandins, iturin A, mycosutolin, and surfactant. All of these drugs contain a lipid bonded to a peptide. Turns out bacteria can produce these molecules as part of their metabolism. For example, Bacillus, Pseudomonas, and Streptomyces all produce lipopeptides. Certain of these lipopeptides are used as antibiotics. Other are toll-like receptor agonists. Daptomycin is a lipopeptide that's used to treat gram-positive, life-threatening infections. Daptomycin is a naturally occurring compound found in Streptomyces roseosporus. It's useful in treating infections caused by multi-drug-resistant bacteria. Its clinical use is in gram-positive infections of skin, Staph aureus bacteremia, and right-sided S. aureus endocarditis. Here is an additional chart depicting a broad overview of the mechanism of action of antibiotics. I'd like to take a closer look at Lincosamides. Lincosamides include clindamycin, the structure of which is shown here. Other lincosamides include lincomycin and pyridomycin. They prevent bacterial replication in a bacteriostatic mechanism by interfering with the synthesis of proteins. It's important to note that their clinical use is an alternative antibiotics for patients who are allergic to penicillin. Clindamycin in particular is effective against beta-lactamase producing bacteria such as group A Streptococcus, which causes strep throat. I'm now going to launch into FDA pregnancy categories. While you folks have likely seen this before in the context of antibiotics, these categories are worth reviewing. Category A drugs are those drugs in which control studies in women failed to demonstrate a risk to the fetus in the first trimester. For obvious reasons and for all practical purposes, there are no Category A drugs. Category B drugs include prenatal vitamins, acetaminophen, and several other medications used routinely and safely during pregnancy. If there is a clinical need for a Category B drug, it is considered safe to use it. If the pregnant patient will benefit from a Category C drug, it's generally used, although most obstetricians would prefer a Category B drug if it will give equivalently good results. Category D drugs are worth noting that there is positive evidence of human fetal risk. Benefits from use in pregnant women may be acceptable despite the risks. For example, if the drug is needed in a life-threatening situation for a serious disease for which safer drugs cannot be used or are ineffective, only when the alternatives are worse. And Category X drugs should not be used during pregnancy at all. Here's another chart showing doxycycline as a pregnancy Category D drug. This particular chart was derived from an AAFP article. If you click on the link, the article will appear entitled Antibiotic Use During Pregnancy and Lactation. Other Category D drugs include aminoglycosides and tetracyclines. Here is an additional chart showing the relative risk of human teratogenicity associated with antibiotic use in pregnancy and lactation. Now, I'd like to talk about antibiotic resistance. There are 5 main mechanisms of resistance to antibiotics to include prevention of a drug's entry into the cell, driving out the drug after it has entered the cell, degrading the structure of antibiotics, and altering the structure of antibiotics. Antibiotic-resistant bacterial strains are spreading rapidly, both in this country and around the world. For example, methicillin-resistant Staphylococcus aureus, shown here, Vancomycin-resistant enterococci, and fluoroquinolone-resistant Pseudomonas are shown here in these 2 lines. I'd like to focus on vancomycin resistance. Vancomycin is a cell wall synthesis inhibitor that's been employed for over 60 years. Bacteria have learned to generate alternate peptidoglycan precursors. Resistant strains produce D-ala-D-lac or D-ala-D-ser instead of the wild type D-ala-D-ala at their C termini. And it turns out the drug vancomycin has a poor affinity for these alternative moieties. Here is a key to what we're talking about. These red circles are alanine. You can see them here. D-lactate, D-glutamate, D-lysine, pentaglycine chain, so-called NAM and NAG, and the drug is shown here in blue. So vancomycin-sensitive bacteria, the vancomycin is able to intercalate into the cell wall and disrupt cell wall cross-linking. These bacteria are sensitive to vancomycin, whereas vancomycin-resistant bacteria have acquired mutations that change the C-terminal from an alanine to a lactate. Therefore, vancomycin, the tightness of fit, is compromised, and these bacteria survive vancomycin because of the poor fit due to this mutation in their cell wall. Shown diagrammatically, vancomycin-sensitive cells, when treated with vancomycin, produce unstable cross-links, and that's how vancomycin kills these bacteria. Whereas vancomycin-resistant cells have this mutation that produces stable cross-links. Thus, the bacteria are resistant to vancomycin. Now I'd like to talk about antibiotic synergy and antagonism. Synergy is defined as inhibitory or killing effects of 2 or more antibiotics in combination are greater than their effects individually. And you can see that here. Drug A in red, drug B in blue. When you add them both together, the log of the number of bacteria present is greatly diminished compared with either drug alone. That is synergy. Antagonism is the exact opposite. You can see drug A alone is fairly effective. Drug B is not as effective. A plus B antagonizes drug A when compared with no drug. That is antagonism. That's where one drug inhibits the action of the other. Major mechanisms of antibiotic synergism include blockade of sequential steps in a metabolic sequence, inhibition of enzymatic inactivation, or enhancement of antimicrobial agent uptake. And examples are shown here. Major mechanisms of antibiotic antagonism include inhibition of cytal activity by static agents, induction of enzymatic inactivation. Pseudomonas aeruginosa, Serratia marcescens, and Citrobacter frundi possess inducible beta-lactamases. So it turns out some beta-lactam antibiotics are potent inducers of beta-lactamase production, to include imipenem, cefoxitin, and ampicillin. That is your introduction to antibiotics. There are a series of practice questions appended to the end of this lecture in either the PDF or PowerPoint. I hope you find them useful and informative. I appreciate your attention and engagement with the material. I think you'll find it useful moving forward throughout your second year of medical school.